Any further discussion? All those in favor say aye. Aye. All those opposed, like sign. Passes unanimously. Thank you. Okay. So that's good. So we do have a hard stop at 6:30. Hopefully we're not going to do 6:30. I know Chairman Strickland has a little bit farther to drive than most of us tonight. Yeah. Oh, yes. Okay. Yeah. Judiciary, we were there till 9:20 a few weeks ago. Yeah. 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 Okay, Mr. Chairman. All right. So let's move on to the next bill. Also, Senator Brass. We're going to Senate Bill 220, and that has a substitute also. And what number are we on there? Chairman?
Is working off of 339799S.
Okay, does everybody have that in their packet? LC 339799S. Okay, hear nothing. Okay. So, floor is yours.
Thank you, Mr. Chairman. So, what I'll do, I'm going to start out by talking a little bit about where this came from, where we heard from patients and doctors. And then I'm going to go through the committee sub, and as I'm going through it, I'll talk a little bit about changes from the sub to the original bill that was introduced with SB220. So really the commission did a listening tour. The low THC commission did a listening tour with patients and doctors that were all within the program. And some of the feedback that came back was it was confusing. The name of the program was very confusing. Some other feedback was that the 5% low THC oil that our state law had put a limit on was too low in many cases. And then also there was confusion around severe under the illnesses and diagnoses. There was a little confusion around severe and end of stage, and then there was also some request for allowing smokables for more quick acting remedies in these cases. And so the original bill went to tackle all of that. And in talking with members of this committee and members of the Senate and kind of facing the political reality of what I think we could pass and what I can't, and still get a win for these patients, we came up with this sub. And so I'll go through that. So first thing we're doing is we're renaming or attempting to rename the program, getting away from calling it low THC oil and start calling it a medical cannabis program. And so you'll see many lines and many strike-throughs that will reflect that. And that kind of starts on where does that start? That kind of starts on page 5 and then really kind of continues throughout the bill. So you'll see, again, like on lines 110, striking through low THC oil and replacing it with the words medical cannabis. As I mentioned in that listening tour, that 5% was a problem for some. And in the original SB220 that I dropped, I was removing the percent altogether and allowing it to go to any level that the doctor and patient should decide. And in talking with the commission, they had done some research and found that in medical cannabis only states, meaning they don't do recreation, The lowest amount they found limit was 50% in these states, and the highest amount limit was 70%. So we had a range, and I believe there's 14 medical-only states. The range is 50 to 70. So rather than do this, basically the original bill was going to allow 100. I decided to bring that down to 50%, which would put us on the lower tier of those 14 states. So you see that reflected in line 88. If you continue over to page 6, because we're going to allow vaping in this, and we're allowing other types of products, we needed to get away from calling it fluid ounces in the law and just doing ounces. So in my original version, I actually wanted to do 1 ounce, but we learned from the commission there are patients out there that are having to travel up to 4 hours to get capsules, and they would like to have a 30-day supply. And so that 2 ounces would cover them for 30 days. So that is the reason that I took it from the 1 ounce to the 2 ounce from the original version to the committee sub. And again, the whole purpose, because we are kind of shifting the product types, we do have to get away from that fluid ounces to the just calling it ounces. If you continue, we struck through from the first version to this committee sub. Years ago, we took out some stuff around the research facilities, and we were touching on that in the first version. I decided we took that part out just because it was getting a little confusing. So you'll see in the committee sub a lot of strike throughs through those sections. So if you'll continue on with me to lines 219 on page 10, this is where we're defining the products. Hemp is not a part of this, and we're making that very clear. And then we're also in the first version, I was allowing food products. Well, we found out decided, because food is also going to be regulated by FDA, and so it's just going to get a little confusing. So we decided to take food products out of this version, and so you'll see that on lines 224. And then under our current law, the gummies are allowed, but there was a little bit of confusion around the law. So if we're striking through the word edibles on line 226, and the idea there is to make it very clear that the gummies are allowed. We already allow over-the-counter sales of Delta 8 and Delta 9 gummies, and there's no reason why we shouldn't allow these patients to take them in the form of a gummy. So we just wanted to make that very clear. Now, line 226 is under products. We're making it very clear that you cannot use flour or as in the old days, I guess you'd just call it straight grass. Flour is the new term for the leaf products. So we're making it clear that these patients can't go buy a bag of weed. And you can't buy pre-rolled, the pre-rolls as they call them. Basically my understanding is it's kind of like a joint, but we're not allowing anything in flour form. Only vape, which I'll get to that in a little bit.
How does this language prohibit it?
Prohibit the grass?
Flower.
The flower. So if you look back up to line 219, product means all products that are derived from or made by processing medical cannabis, blah, blah, blah. And then but not including on lines 222. But not including hemp. We're not including cookies or candies, and we're not including raw plant material. Does that answer your question?
Yeah, thank you.
Okay, thank you.
That but not including.
No problem. So continue on. You'll see page 11, more strike throughs on low THC and replacing with medical cannabis. Getting on to lines 274. This is where we're making it very clear that the commission does have the ability to educate the public, educate patients, educate doctors, and they need that ability. We want the professionals to be able to do that. Continue on to lines 326. This is on page 14. This is where we do not allow the license holders to, I'll just remind everybody we have six license holders, so 2 in Class 1 and 4 in Class 2. They are not allowed to advertise, but again, we learned in that listening session, listening tour, that there needs to be more education out there. So we wanted to allow a third party like association can educate public and doctors and patients. They can't advertise for one particular brand over another. It's just they can advertise, or not necessarily advertise, but they can educate. And so that's making that clear there in lines 326. Continuing on, there in section 3.7 on lines 389 through 391. This is where we are repealing the entire code section of 16-12-234. That is the code section that talks about electronic cigarettes, talks about electronic cartridges and the igniting of those cartridges. Essentially what this does is it allows vaping for this product. Again, and I think we're going to hear some testimony from possibly doctors and patients, but there's a need for a more fast-acting for some of these patients that an hour or 2 hours, whatever the normal wait time is, just isn't taking care of these patients the way it needs to. So that is that section. And then getting into section 3-10, this is on page 18. This gets into the conditions. Now, if you'll remember, those of you that were here years ago, we put in a provision when we set up the original study committee to figure out how we were going to set up the program. We put in a provision. Really, it was on sine die, if I remember correctly. Dr. Watson and I worked on it together to set up that set up that study committee. We put in a provision that DPH, in conjunction with the Composite Medical Board, would make recommendations on putting illnesses and diagnoses on this list and taking them off. So I think there's a letter in everyone's folder. We have from the Georgia Composite Medical Board, signed by Executive Director of that, Jason Jones, and also our Commissioner of DPH, Commissioner Toomey. So in that letter, they have asked that we remove Crohn's disease and rename it inflammatory bowel disease. So you will see that on line 440. And then they also asked us to add lupus to that. So we did that on lines 456. Now, going back to the listening tour about from doctors and patients, having that severe and end of stage was a little confusing. So I did remove that in both versions. But I did add some language that I think kind of helps, and that is you'll find on lines 429 through 4032, and I'm going to read that. It says, condition means any of the following provided that the patient's symptoms associated with any such condition can reasonably be expected to be relieved by the use of medical cannabis, and the potential benefits of such use to the patient outweigh the potential health risks that such use might pose to the patient. And that makes it clear that this state is saying, all right, look, this is kind of a last resort, and we understand that, and we want the doctors and patients to, when nothing else is working, give it a shot. And so that's kind of what that statement, where that comes from. Some other little changes we did make. This was at the request of the chairman on skin cancer. We've tightened up. We're allowing with cancer, but once we removed that severe or end of stage, it kind of opened it up in within skin cancer to where we don't think it necessarily should be included. So what we did do there is we said accept skin cancer unless it's a specific type, which is metastatic skin cancer, and I'll let one of the doctors elaborate more on how that could be a need. But other than that, that's pretty much what we did on the conditions. Now, from the original version of SB220 to the sub, I did go back on under autism, and I re-added the language of with autism, you still got to be 18 years of age or severe autism when diagnosed for a patient who is less than 18. So that was not in my original version. It is in the current law, but I did want to go back and put that in after a few meetings, and honestly, I think I just kind of missed it. One last thing we made a change to under on line 452 under peripheral neuropathy. Again, once we removed that severe end stage, it was kind of opening up for carpal tunnel, which we think might not necessarily be needed. So we came back and added that language when such symptoms are diagnosed as severe. And my understanding is there is no such thing as end stage peripheral neuropathy. So it ends at severe. So that's what we added. And Mr. Chairman, that's pretty much it for going through the bill. I think I've highlighted everything and more than happy to answer questions.
Yeah, so do you want to answer questions, or you want the testimony and then answer questions, or how do you want to do that?
Let's get, I tell you what, I guess we better get through testimony. For those of you testifying in favor of this, I'm going to ask you to be very brief because at 6:30 we're going to lose votes.
So that is accurate.
Maybe a little
We've had
earlier.
5 people to sign up to support this and 1 to oppose. It's 5:58 now. Let's limit the support to no more than 15 to 20 minutes, and we're going to time you. And then the opposed will give you 5 to 10 minutes. And use your discretion. It's late in the day. We went long in the floor session today, so that's where we are. No more than 10 minutes for opposed. Only one person has signed up for that, and then 20 minutes to support. But y'all decide on how you want to spend the time, but with the knowledge that we'll probably lose quorum in about 30 minutes. So first
Can we
one,
do oppose first?
if we want to do oppose first,
If they go over.
certainly. Oppose is Georgians for Responsible Marijuana Policy, Michael Mumper. Okay. So the floor is yours.
Thank you, Chairman. Thank you, Senators. I'm Michael Mumper with Georgians for Responsible Marijuana Policy. We're a nonprofit organization that is trying to protect Georgians from the harms of marijuana. With all respect to Senator Brass, I respect him as much as any senator I know. I do think that this is a significant bill that really opens up the doors. Without being redundant, some of the things we're more concerned about. One is increasing the potency cap from 5% even to the lowered 50%, 10 times as strong. And especially when we consider that vaping will now be allowed. So we're talking about vaping 50% THC products. That'll be fast-acting and extremely powerful, and the medical professionals that I talk with and peer-reviewed journals are showing that this is having a devastating impact on schizophrenia, psychosis, and suicidal ideation. I think, I don't know if the other states that have legalized that high of rates are taking all that into consideration. Secondly, opening it up to really any qualifying condition. And while it is a medical professional who's going to make that determination, there are medical opinions across the spectrum. And there are going to be doctors who are much more liberal about their ideas about medical marijuana's benefits compared to what I consider the overwhelming consensus opinion of marijuana is that it should be taken extremely slowly, wait for science to prove this, and I think we're going past that. There's going to be doctors who will certify conditions for marijuana that is really iffy and probably against consensus medical marijuana opinion from the medical profession. And those doctors are going to get a lot of business because people are going to find their way to those doctors. And the last point I'll just make for today is the advertising. We're kind of opening up a new door to advertising, and what we've seen in other states is that every loophole that can be gone through as far as educating the public will be gone through, and we could have signs, TV ads, newspaper articles that our kids will inevitably see and take note of and see the overwhelming social normalization of marijuana. Our concern is that right now we have 25,000 Georgians on medical marijuana. If we start to emulate some of the states that have legalized and we approach that per capita ratio of about 3 to 4%, 3 to 4% of Floridians, for example, are registered for medical marijuana. What we'll experience in Georgia if we ramp up the same way is going from 25,000 to 300,000 or 400,000. So we're 10, 15 times growth. It's good for business. I don't know if the science would support that. I appreciate the fact that we're in Georgia and we've taken a more methodical approach of balancing business with science, but I think that this bill really opens that door to the business model of marijuana. With that, I'm done for now. Thanks.
Thank you. We appreciate that. In the order of testimony, so the 20 minutes of support, we've got Georgia Medical Cannabis, and then Angels of Epilepsy, and Whole Plant Wellness, Alliance Spine, and Leading Age Georgia. You can wave and say, I support it, or you can testify, but everybody has 20 minutes.
My name is Yolanda Bennett with the Georgia Medical Cannabis Society, and I come to you today not as a representative of the Georgia Medical Cannabis Society. I come to you as a patient. And I basically have so many conditions that I just have to go ahead and notate. I had to write it down. The reason why I support this bill is because it's not a comprehensive program right now. I recently tried to when I traveled to Hawaii and was trying to get my card there, they told me that I couldn't get a temporary card there because Georgia doesn't have a comprehensive program. And my issue is also inhalation. We need inhalation. I need all forms of cannabis so that I can treat my conditions. I suffer from papilledema, intracranial hypertension, empty cellar. I have osteoarthritis. I'm in need of 2 shoulder replacements, 2 knee replacements, and also a hip replacement. I have lumbar stenosis, cervical stenosis, Cushing syndrome. This all came from high-dose steroids. And the only thing that was able to wean me off of those high-dose steroids was cannabis. They tried to wean me off before, but they couldn't. And the only thing was cannabis. I ended up having a steroid crisis. So I urge you to go ahead and vote yes on SB220. Thank you.
Thank you. Appreciate your sharing your story with us. Natalie Beavers, Angels of Epilepsy, and then and Whole Plant Wellness, Mary Adams. Okay.
Hello, everyone. I am Natalie Beavers. I've been living with epilepsy for 43 years, and I was born and raised right here in Atlanta, Georgia. I was diagnosed with epilepsy at the age of 5 in 1982. Back then, there were little information and resources available about epilepsy and seizures, so my parents had to conduct their own research to get a clear understanding that could possibly better my condition. And growing up with such challenging brain condition, there were many activities that I couldn't participate due to my seizures. However, I truly am grateful for my family, my friends, community for their support and not passing the judgment. Unfortunately, today, it remained difficult for children, teens, and adults living with epilepsy to navigate those challenges. I became an advocate for the epilepsy community 14 years ago, realizing the need for our voices to be heard. In 2013 and 2014, I was inspired when I heard Senator Alan Peake speak about the potential benefits of cannabis oil for children with epilepsy and seizures. I watched a heartbreaking video of children who had been having seizures, over 100 seizures a day, and how families had to move to other states to receive cannabis oil. The difference it made in their life was incredible, and it was an emotional response for their family, and it touched many hearts deeply. I have relatives in Nevada and California, so I decided to try cannabis oil for myself to see if it could help control my seizure activity. I would travel there for 10 to 14 days just to allow the cannabis oil to fully affect, then return to Georgia. After my first trial, and again, this was years ago, I went 72 days without a seizure. On my second trial, I call it a second trial, I was seizure-free for 90 days. This experience convinced me that cannabis oil could benefit both children and adults living with epilepsy. I decided to become a cannabis oil advocate and started attending the sessions here at the state capitol to support those affected with epilepsy. Governor Roy Barnes played a pivot role in passing the bill not only for children with epilepsy, but also for adults, which was a tremendous victory for the epilepsy community here in Georgia. We were overjoyed, and we remain incredibly grateful for this support. In 2016, I received my Georgia Cannabis registration card, and it has significantly helped me manage my seizure and anxiety as well. However, I found that the prescribed dosage of the cannabis oil, it sometimes doesn't provide the relief that I need. After speaking with others in the epilepsy community, many of them shared similar stories. I truly believe that increasing the dosage of cannabis oil for epilepsy patients could greatly reduce seizure activity for so many people and also help us to live a better life, just as other people. I am asking all of you, council members, senators, to consider the difficulties faced by epilepsy survivors as well as parents and caregivers in this community. We deeply appreciate your attention, and we would be incredibly grateful if you would support passing SB
Thank you, Ms. B.
220.
We appreciate that. Just next up is Mary Adams.
I'm just going to keep it short from my chair and staff.
If you wouldn't, sort of just for those at home.
We are very much in support of this bill. I'm here on behalf of myself, and I own a medical cannabis doctor's clinic, so I'm here on behalf of my patients, the youngest of which is 3 years old, the oldest of which is 92.
Okay.
We are very grateful for the listening tour and for the GMCC in allowing our patients to speak and to let you know what we really need from the program. We're really grateful to have a medical program, and we're very much in favor of this bill. Thank you.
Thank you. Okay, Alan Horde, Alliance Spine, Dr. Horde. And just for clarification, we are at about 13 minutes total. And I would like to hear from the commission maybe just to answer a question or two. And the floor is yours.
Thank you, Mr. Chairman. I appreciate being here, but I didn't plan on it, as you can see from my clothing today. And I've been a doctor in Georgia. I've had my license for 40 years. I've shared patients with Dr. Kirkpatrick back in our younger days. And as many of you know, my wife, Terry, has multiple sclerosis and has been here talking to some of you guys before about issues related to MS, including medical cannabis. And this is the first I've actually heard a lot of the detail of the bill, including the part about changing some of the restrictions on the diagnosis. And I'll give you an example from my wife, who is, those of you who know her, is basically quadriplegic from multiple sclerosis and has a use of 2 fingers on her left hand. And she went to see one of the medical cannabis doctors and was told that her condition wasn't severe enough to qualify, which I was astounded that anyone could interpret the law that way, but I think that's exactly what the new wording is leaning toward. I also wanted to say something about concentration, because as a doctor, we use drugs of different concentrations, and we know that the most important thing is the dose itself and not the concentration, in the sense that if it's a higher concentration, we're usually giving a smaller amount. And that's one of the things about using inhaled marijuana, THC, is that it would be a smaller amount, and the necessity to have a more concentrated solution so it can actually be stored in a vape pen. So it's not just about increasing the amount that people can get, but making it available in a different form. And the last thing I want to say is that these going to inhaled applications is very important to our patients, because they're really looking for that onset of action. Taking the oil or chewing on a gummy takes a while to work. Patients are very anxious. They're looking forward to pain relief, relief of their nausea, relief of their anxiety, and they have to wait too long to get it. And this is especially important in our cancer pain patients. They need faster onset. If you think about it, we give pills to patients at home, but when they come in the hospital, we're going to give things intravenously usually, because we want that faster onset of action for the patients in need. And this gives the opportunity for patients using THC at home to have that faster onset.
Thank you, Dr. Horde. Appreciate that. Appreciate your insight as a caregiver and as a physician. Jenny Helms, Leading Age Georgia.
I'll be very brief. Jenny Helms with Leading Age Georgia. We support nonprofit senior housing and services. We've been working with the Emory doctors, geriatrician, palliative care specialists, as well as Mikkel Kogan, who is a geriatrician and integrative care specialist out of George Washington University, and we're seeing that it has great impact for older adults, both with the pain as well as the agitation, anxiety, and restlessness common in Alzheimer's. And we've been working with the Medical Directors Association on education. We think that this is a very very important bill. We thank you for shortening on Alzheimer's because that agitation happens early, and we think this is a great bill. Our biggest challenge is getting it to the residents. We've done education in long-term care, and they are very excited about it. Some of them have already gotten their cards and gotten it, but we do in the future need to add where it can be delivered or that a caregiver or someone else can pick it up.
Thank you, appreciate that. Okay, so that's everybody who signed up to oppose. And do you mind, Ms. Head, did I say oppose? Oppose and support. I left off the and support. Ms. Head, do you mind coming to the podium and introduce yourself? Jansen Head is General Counsel, Georgia Access for Medical Cannabis Commission. And I think is this the first time you've been in front of the committee?
Yes, Mr. Chairman. that's
How
right.
long have you been with them?
With the commission?
Yes.
About 4 years.
Oh, I didn't realize it was that long. Thank you for being here. She's just a wealth of knowledge, and just maybe could clarify some statements. Just one thing is that it was Governor Nathan Deal, if I remember correctly, and not Roy Barnes. So that's one clarification. Thank you, Ms. Head.
So my name is Jansen Head. I'm the general counsel to the Georgia Access to Medical Cannabis Commission. We also have our director here, Mr. Turnage, as well. But we appreciate Chairman Brass for asking us for input. We've seen many bills over the years about the program. This one actually focuses on responding to patients. So we really appreciate that. And I'm just here to answer questions, to give data, however I can help.
Okay, thank you. I had one question, and I couldn't remember it, and I think that Chairman Brass, how many states surrounding us and the 50 to 70% that? Could you go over that for us again, please?
Yeah, so around the country, if we look at more of the medical-only states, meaning it's not for everyone, you do have to have a condition. For medical-only states like Georgia, there is 18 of us. And if you look at this bill and what it proposes, and you don't always want to look at what other states are doing. You want to look at your own constituents and see what helps them. But increasing that potency level does put us more on par with what medical-only states do. And what's unique in Georgia is, unlike those states, Georgia requires half of those conditions to be severe and end stage. So we require more severe conditions but low potency. And so that's why patients came out in our listening tour last year and asked for more.
Okay. Let me open it up to Chairman Kauser. You're on W3?
I am, thank you. So I just want to make clear, the commission did not ask for this legislation other than to add the two conditions, lupus and to change the Crohn's disease.
So that came from the Department of Public Health and the Medical Board. This bill was more sort of a response to our listening tour.
Right.
So we don't ask specifically for or against something, but when we look at this bill, it responds to what our patients have asked for. And that tour, it quotes several of our patients. We had about over 150 participants that spoke to us.
Can I follow up just one? So in your booklet on the listening tour, you make it clear that the comments in here were just what you heard, but that it was not a request by the commission for these changes that the patients wanted, right?
It's not an agency bill. I mean, we really haven't asked for anything by the General Assembly, including more licenses, anything like that. But this bill, we didn't really expect for the commission to drive it. It was driven by our tour. So every year, the General Assembly asks us for recommendations. So when we sent our report and our recommendation in January, we sent that report as our recommendation.
So you were recommending all these things brought up by patients in the listening tour?
If the patients ask for it, then we're going to support that.
All right.
Follow up, Chairman Brass.
Yeah, I just kind of want to say for the record, I met Ms. Head for the first time in Dr. Kirkpatrick's office like 2 days ago. I have known the executive director Turnage since he got hired. But no, this bill did not come from the commission at all. I read the listening tour, which came out to, I think by law, they have to issue their annual statement to this committee. And when I read it about a month ago, maybe 2 months ago, it came out. As I was looking through that, I did notice the listening tour, and that's when I started scrolling through that. And at that point is kind of when I decided that we should try to do something. So I just wanted to say that for the record.
Okay, thank you. Chairman Hustetler, you're on mic 12.
Well, I had another question, but hearing what Chairman Cowser said, I'm trying to follow up here. So there wasn't any like scientific study done on this. You just said if you listen and somebody said, I want it stronger, or I want it in vape form, or whatever, they requested that you supported it. Is that what you're saying?
Well, I can add to my response. So, I mean, when patients come and speak and they have a card, we don't want to question them, to have them bring their medical records. We want to hear from them. Mm-hmm. We also had physicians who are licensed in Georgia speak on it. But on the research part, I mean, this body made our program based on their own research 10 years ago. I mean, you guys also scanned the states at the time, and so our program was based on that research done back in 2014, I believe. But the research part is there, but the tour was focused on how are we serving patients on the registry now.
Mm-hmm. So then the other question is, what's the minimum age to be on this program?
On the program, it's up to the doctor. So if you look
I heard
at
the 3-year-old, I'm trying to say you can be 3 years old and be on this program.
Yeah.
So I mean, I know the American Academy of Pediatrics is strongly against that. So that's just a little bit surprising to me.
Yeah, I think one thing that when this was passed back in 2014, 2015, there was a lot of, not assumptions, but you could see that a lot of activists or patients that came were children. But if you look at the current report from DPH, and I've got a copy, but DPH issues a report every week to show you the makeup of the registry. So we have about 27,000. Over 50% are people over the age of 50. 99% are people over 21. And less than 1% are people under 18.
I'm sorry. Just historically, you were here and I was here. The initial aspect was for children with Dravet syndrome who were having multiple seizures. As when I say multiple seizures, I mean dozens a day. And that is actually, we passed that more anecdotally. Since we passed it, there's been at least 2 articles published in the New England Journal of Medicine, our go-to journal, and that showed in Dravet syndrome, that DRUVET, apostrophe S, that it was successful. And that's sort of confirmed. And I think that's partially what has led the FDA and DEA to readjust that and allow studies on that. Certainly, W3.
I'm holding your patient listening tour reflections report in my hand, and it reflects that the Georgia Department of Public Health, the Georgia Composite Medical Board, and the Georgia Board of Pharmacy did not participate. And on page 3, you say the summaries presented and other features in this report are based on the opinions and perspectives of the participants and should not be construed as an expression, perspective, practice, or viewpoint of the commission. Are you now saying this is your recommendation, even though your report says it's not?
No, I did not say that it was our recommendation. We did invite those agencies because they do each play a role. So the medical board regulates physicians. I know Senator Kirkpatrick and I are kind of working on that with educating physicians. That's a different battle, but we also work with public health to handle the registry. They make sure that the doctors recommending patients are submitting the right information. So we invited them, and they were not able to be part of our panel, whether it's for scheduling. This was during October, November, and we thought it was important to still have a listening tour and have them still be heard. And we shared this with those agencies. We told them what it was about. This is not, it says it's not a recommendation because each commission member may have their own opinion, and we wanted to be respectful of that. But when we approved this report in a commission meeting, and it was a full vote of everyone supporting the report, our chair did say that this was our recommendation, that we did support this. The product is not for us. It's for the patients and those that spoke.
Thank you, Ms. Head. Any
Yes, sir.
other questions at all? All right, Ms. Head, you can step down. Appreciate your input and insight. In your folder is the recommendation from DPH and Georgia Composite Medical Board about their recommendations. Okay. Wait, line four?
Yeah.
Mike, want to pull your mic up?
I mean, he's sitting right here. It's in relation to the misdemeanor part, like if they don't have their card or it's not labeled correctly. Just wanted to clarify, like, because people forget things. So is there any discretion in exercising that? I mean, legit, people just might have left it at home or, yeah.
Right. So we didn't touch any part of that law except for changing the fluid ounces to 2.0 ounces. That's the only part of the current law that we touch. So I wasn't getting into all that, but we can discuss that at a later
Just want to make
date.
sure we're actually helping them,
Yeah.
not getting them in
No,
trouble.
I agree.
You can talk to me, okay.
I'm not online, so you're at line 12? 12?
Page 7, I noticed all these penalties were stricken out, and if I'm reading it right, and maybe this is ledge council or whatever, but I guess it refers to chapter 13. What is that?
Could get legislative counsel to page 7. And while you're doing that, why don't you go ahead and ask your question, Senator Kirkpatrick, or did you have a question?
I do.
Okay, and you're on number 9?
7.
7, sorry.
And so since Ms. Head brought me into it, I'll just say that we have been working on figuring out an education program for physicians because right now there's very little that's available. The other thing, just a question that I want to ask, I guess I want to ask the author. I've been trying to review some literature in preparation for this, and I'm finding lots of studies about vaping and the effect on the lungs. And in fact, there's one from Thorax magazine, which is the chest magazine, that talks about cannabis vaping being more harmful than nicotine vaping. And so I don't want to go through point by point through the bill, but I am concerned about vaping, and I just wondered if you had run across any of that literature.
Yeah, I mean, not that I'm aware of. I'll be more than happy to review it, but I think the importance of, we've heard from the doctor on the need for vaping, and I'll add that if we're going to allow that, which I agree we should, increasing that percentage is going to be important, because a person that's chasing a high, if you will, if they're trying to get to, say, that 50%, well, they might vape 10 times instead of one time, getting that 5 times 10 to get to 50. The other downside of leaving it at 5%, assuming we're going to allow vaping, is the additives that go into it. So there's less additives that would be a part of that vaping. And for these patients, and you look at some of these illnesses, some of these diagnoses, and I look at like ALS.
All right,
and
you may be talking us out of it here. Do you have another question there?
Well, I'm going to finish real quick, Mr.
All right,
Chairman. The
okay.
ALS, if you've got ALS, your days are limited. And being able to vape, having the risk of vape is going to not have anything. I'd much rather risk that. So,
All right.
Can I have a follow-up,
Sure.
Mr. Chair? Yeah, just, I agree with you about ALS, but there's a lot of conditions on this list that people are going to live with for decades, and
Agreed.
not just
But
weeks or months.
that
And
is-
so
that is-
We're trying to make it better for
I do have a
them.
concern about the
okay.
respiratory effects.
I
Thank you.
think we all do from a
Yeah.
vaping standpoint, but the issue is that when they are vaping, it will be, the quantity will be reviewed, the percentage will be looked at, and it will be run through the science from that standpoint. So it's somewhat reassuring, but still a challenge with vaping and all. Ms. Crittenden, you're on witness too. I think you were
Yes, sir.
going to answer that question from Senator Hufstetter.
Yes, sir. So I believe the question was on what the striking through is on page 7.
Yeah.
And so what they've done is for the main part is in section D, we're removing the felony. It's no longer a felony. And the upper part, they're still allowing a misdemeanor, which comes back. It's basically what we're keeping, which criminal penalties we're keeping, which is we're removing the felony and allowing a little bit of misdemeanors for a 2.0, having more than, let's see.
So that's what's
To
in
it.
chapter 13 on line 151, 52.
That all applies for folks involved in the clinical research program, which we've striken all that we're not making any changes under clinical research program. When I took the clinical research language in the original version, we're taking all of that out, and I think that's what we're seeing there. Is that not right, Sarah? That was the intent of the sub.
Correct.
Okay.
All right, any other questions? All right, thank you. Thank you, Ms. Crittenden. No further questions. I'll be happy to entertain any motions. Motion from Senator Merritt. Motion do pass. All right. Do I have a second?
Second.
Second from Senator Strickland. Any further discussion? All those in favor, let's raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. That was 8. All those opposed? 1, 2, 3. 8 to 3, it passes. He did. Yeah. Thank you very much. And it's 6:33. Thank you so much. Meeting adjourned.